So this afternoon we have Dr. Gary Noritz with us. He's an internist and pediatrician at Nationwide Children's Hospital and a professor of pediatrics at The Ohio State University. He is chief of the Division of Complex Care and serves as chair of the Council on Children and Disabilities of the American Academy of Pediatrics. He graduated from Brown University School of Medicine, completed his internal medicine and pediatrics residencies, plural, at Metro Health Medical Center, Case Western Reserve University School of Medicine. He is board certified in internal medicine, pediatrics, neurodevelopmental disabilities, and hospice palliative medicine. So without further ado, Dr. Noritz, ready to go?
Hey, thanks everybody for coming. I'm glad to be here. I was here a few years ago. That was, in the old days before the pandemic. Had a good time. So thanks for inviting me back. Again, I'm Gary Noritz. I live here in Columbus. I work at Nationwide Children's Hospital. I run a program called Complex Care where we take care of kids, mostly kids, but also some adults with disabilities. My training's in both general medicine and general pediatrics, but my practice has always been taking care of kids and adults with various complex kind of problems. And I'm glad to be here today to talk to you about pain, which is a big topic for everybody in the world, but particularly in arthrogryposis. Housekeeping kinds of stuff. I don't have any financial disclosures to tell you about. I am going to talk about a few medications and therapies that are, as we say, off-label from the Food and Drug Administration, which is honestly most of what we have in medicine is things that are off-label. If they're approved for anything, a doctor can prescribe them for something else. And often we've been doing that for decades or even 100 years, and just nobody's bothered to spend the money to do the study that says, yes, this works for that kind of thing. But I'll be clear about that as I go through. Okay, so goals for the talk. I want to talk about different types of pain and what causes them, and different medicines and modalities that we use for pain management. Now, when I was in high school and growing up, I was a soccer goalie, so I was on the other end of like trying to keep people from getting to the goal, but here we're going to get to the goal a little bit. And I did dig this picture out sort of recently. That's me from behind in high school. You can see my mighty mullet just a little bit. And so about me. So I trained in internal medicine and pediatrics, and that's a reasonably common training pathway these days for people that like taking care of people regardless of what age they are. And I've always worked in this thing called complex care, and I've always been really quite amazed at what my patients and their families can do. And it's just a matter of, you do what you got to do, and you get through it. And I appreciate all the learning I've done from my families over time. So a lot of what we deal with in the clinic and in the hospital is pain. So let's stop for a minute and think about what pain is. I mean, you hear it and you feel like you know what it is, but of course somebody had to define pain, and we do it in a broad kind of way. And so this is the International Association for the Study of Pain, and how they define pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And so we'll talk about that for a little bit, because pains can be really complicated. There's to some extent what you might think of as easy kind of pain. You bang your finger with a hammer. You step on a nail. You fall off of something and break something. Like that. That's pain that seems fairly easy to understand, but there's so much more to pain and to the pain experience than just, I have damaged tissue. So some key notes, because I think, most people that have experienced pain and have tried to interact with the medical system around their pain have found it pretty frustrating, okay, and I myself have. So to go back again to the International Association, things to think about. Pain is a personal experience, and it's influenced by a person's biology, psychology, and social past. okay? And so something that hurts me a particular way, if the exact same mechanism happens to somebody else, may not hurt in the exact the same way. It might hurt me more than them, might hurt them more than me. We talk about this sometimes in terms of like the pain threshold, and who's tougher than other people perhaps, or what kind of pain people have had in the past. So pain and nociception means the sensation that a nerve has that the brain understands as pain. Those are different phenomena. Just because we're able to activate a pain sensor doesn't mean that pain is happening at that same time, and vice versa. Through a life experience, a person learns the concept of pain and how they will cope with pain for better or for worse. That has to do with, the experiences you've had growing up, the experiences people in your family have had around pain, acute and chronic, and how you deal with the world. Pain serves an adaptive role. Like, that's why we have pain. Like, if you touch a stove and it's hot, you don't have to think about taking your hand away. That happens automatically. So that's an adaptive way to think about pain. But sometimes pain can be maladaptive, and this is usually what happens when we have chronic pain, particularly when it's not due to an ongoing tissue trauma, when there's pain that goes on that sort of lives within the nerves or the brain and so on. We'll talk about this. And something that's really important, not so much in taking care of my patients with arthrogryposis, but a lot of my other patients who don't have great verbal abilities, is just because you can't tell me you don't have pain doesn't mean you don't have pain. So babies can have pain. Our patients that are nonverbal can have pain. Animals can have pain. We don't sort of question that. And if I rely a lot on my patients' family members to interpret their behaviors, their facial expressions, the sounds they make, to say, do we think this behavior is indicative of pain or not? And if you tell me you're having pain, I believe you. And if your parent tells me you're having pain, I believe them because they know you pretty well. Now, pain is a little bit different from suffering, and I just pulled this out because Dr. Castle, I saw him speak once. It was one of these things where it was like just riveting, and you're glued to your seat, and you didn't even realize an hour had gone by. So he was one sort of the grandfathers of palliative medicine, this field of medicine which says, in medicine, we should make you feel better. And, isn't that what all of medicine is, right? But we get away from that a lot in what I would consider sort of our compartmentalized Western kinds of medicine. So anyway, he talked about suffering. Just because you have pain doesn't mean you're suffering. And you can be suffering without pain as well. And lots of things cause suffering. And that's what he described as sort of attacking the intactness of a person. And one of the great things I thought about, or that he said during this talk that I saw him give, was sort of once he knows a person, he'll go into the room, he'll sit down, he'll say, so, and the person who knows him will just talk and tell him what's up. And an hour later, the session is done, essentially. He wasn't a psychiatrist, he was an internal medicine doctor, but what he really honed in on was the interaction between a person and their physician, who, if they know how to listen well, to discuss what's pain and what is suffering. Now, Cicely Saunders was really sort of the grandmother of the palliative and especially the hospice movement. And she was a nurse by training who talked about this concept of total pain. It's not just physical pain. People have emotional pain and psychological pain and spiritual pain. And why is this happening to me? That kind of thing. And it all runs together. And you can't separate out somebody's physical pain from their spiritual pain. It all runs together. And to do well in managing somebody's pain, we have to get past this notion of, well, if I just fix, this joint that's rubbing together the wrong way, then your pain will automatically go away. Because it's not just that. It's how your body and how your soul experiences pain. People have anxiety and depression. I know I have anxiety and depression. Everybody I know has some amount of anxiety and depression. And when you have pain, your anxiety and depression gets worse. Yeah. And when you have anxiety and depression, your pain gets worse. And you cannot treat one without the other. And I'll say to some extent, luckily, a lot of the times, the medicines we use are good for both pain and anxiety and depression. So what do we know about pain in arthrogryposis specifically? So there's a few things being written about it. And so right when I walked in, you walked in and said, so my granddaughter has pain. I guess that's normal. Okay? And I think that's a great question. So let's sort of think about what that means. If almost everybody has pain, 71% of adolescents and 89% of adults, does that make it normal? It makes it typical. And so we can spend a whole hour, I'm sure, discussing what's normal and what's not normal. But the way I think about it is, it's typical. You can normalize it and say everybody has some pain. But that doesn't mean we have to sort of like it. It doesn't mean we have to accept it and not try to do something about it. The problem is, it's awfully hard to get rid of somebody's pain totally. To take somebody who has chronic severe pain or even chronic moderate pain to zero pain is pretty hard. And a lot of what we do in pain management is say, well, let's get the pain down to a level that's acceptable. Now, what's acceptable to me as the doctor is not going to be acceptable to you as the patient, but what I tend to, when I'm working with people, what I try to do is get to what can we do to get you functional, okay? Not just, yes, we have a pain scale and the government says I have to ask you, on a scale of 1 to 10, is it 8 or is it 10, and can we get it down to 3, and that kind of stuff. I don't care about the number. What I care about is what can you do better if we can get your pain down, and what is your pain keeping you from doing that. So just from this one study, and this little graph right here is sort of an interesting thing you can do in the medical literature, is type in pain and arthrogryposis and see how many papers have been written about that over time. So like more and more papers are being written about this. More and more people understand it. I think it means more and more doctors and therapists and people are interested in this topic. So we're getting there because people are interested in it. Certainly everybody who has the pain is interested in it. But what do we know? It's more common in adults than adolescents. It's more common in the lower limbs and in the spine. And the more, to some extent, the less ambulatory ability somebody has, the more likely they're going to have some pain. Okay, let me stop there.
So the less
Go ahead.
they move or are moving, the less pain they're going to have?
That was, no, sort of the opposite. The less movement somebody has at baseline, the more likely they're going to have pain. Doesn't mean it's because they're not moving as much. Doesn't mean the people that can walk don't have pain. It's more of just a likelihood kind of thing. So I kind of carry this list around in my mind of like things that cause pain, because I often see patients who don't have verbal ability, who can't say to me, my foot hurts, but they may have a change in behavior and they may be crying or they may be screaming or they may be hitting themselves, and their family member will come to me and say, I think they're having pain. I don't know where it is, but I think they're having pain. So in my mind, there's a list of like a million things that can cause pain in the human body. These are things I try to think about as I'm sitting with a patient and a family. The ones that I bolded are things that are probably more common in people with arthrogryposis than people without arthrogryposis. And so I don't know that I've ever seen a study per se that says there's more kidney stones in people with arthrogryposis than not, but almost everybody I take care of who uses a wheelchair for some reason or another tends to have more kidney stones. Kidney stones are more common with the more immobility you have. People tend to have more fractures in arthrogryposis. Bone density is probably not as good in arthrogryposis. Bowels probably don't work as well in arthrogryposis. And this is probably the one that I think is the biggest culprit for most of you and for most of us, is these overuse and abnormal body mechanics syndromes. And so, what I learned in medical school about the, quote, normal human body, like the perfect human body, number one, doesn't exist. And like number two, none of us have that, and every one of us has, one foot that's a little bit bigger than the other, or one leg that's a little bit longer than the other. And for people with arthrogryposis, that is, sort of what, the core of what this is. And so what have you done with this limb with a contracture in it that's maybe shorter or longer or what have you? You've adapted, okay? You've adapted by necessity. You have to have function. You have to do the things you got to do. But when you adapt, just as, as somebody has, one leg a little bit longer than the other, you make up for that in the way you adapt. You stress other joints, and it's the other joints that really can run us into problems. And overuse syndromes, I think, are real common. So, I have patients of mine that have manual wheelchairs where they are constantly wheeling their wheelchair for their mobility. They get a lot of overuse problems in their shoulders because they're constantly doing this. The shoulders are not built to be your mobility muscles. Your hips are. But if your hips and legs don't work and you use your shoulders, you get an overuse syndrome. If you are using a joystick and the joystick is not ergonomically placed well for you and you really have to contort your body to use it, you'll get an overuse syndrome. If you, came and watched me sit at my desk and type, it'd be a nightmare to say, why are you sitting like that? You're straining your neck, you're straining your back. I certainly feel it at the end of the day. And I don't have arthrogryposis. I have a, quote, normal body. But I can tell you I don't have a, quote, normal body. I have a 50-year-old body. Over time, that body has gone through some changes. Nerve impingement. And so, how do we carry pain? How do we understand pain in the body? There are nerves that go from your brain down your spinal cord, out from your spinal cord, to your arms, legs, hands, and feet. And lots of people can have impingement, which is to say that there's something pressing on the nerve. Sort of the most common one probably you've heard of is carpal tunnel syndrome. And so people can have pressing on the nerve as the nerve to the hand comes out through the wrist. We call that carpal tunnel or median neuropathy. But anywhere that you have a bone pressing on a nerve in the wrong way, you can get one of these nerve impingement kinds of syndromes. Pressure ulcers. If you are putting pressure on a part of the body constantly, you're cutting blood supply off to that. And so a lot of my patients who use wheelchairs and sit in wheelchairs all the time can get a pressure ulcer on their push or on their hip or any place that they put too much pressure on at any one time. And so, if you use a wheelchair or even if you don't, it's really a good idea to shift your position from time to time. I remember when again, just times that I've been kind of sick in bed, I had COVID pretty bad, not super bad, but I was stuck in bed for a few days. I laid in one position, and I'll tell you, my skin did not like that. And you got to move around. You got to flip over to the other side. And I like to mention this thing called wandering spleen, just because I have one patient with arthrogryposis and I have one patient with wandering spleen, and they're the same person. And so I don't know that that's any more common in arthrogryposis than anything else. But wandering spleen is just, I think, the greatest name for a syndrome ever. Essentially, your spleen is this organ that sits up here under your rib cage. It's a big lymph node, essentially. It works in the immune system. It's hung up here by a ligament. And in some people, the ligament can be loose and the spleen can sort of drop down lower than it belongs. And that itself shouldn't hurt, but if it gets twisted around, it can hurt. And they call that wandering spleen. So, the first time I saw that on my patient's CAT scan, oh, and by the way, they have wandering spleen, I'd say, wait a minute, you're making that up. That can't be a real thing. But it's a real thing. I looked it up and it's there. So, all right. So those are, and then the other part of this is that a lot of these are pretty simple, benign kinds of things. We all get headaches. We all get hangnails. We all get constipated and gas and that kind of thing. But part of the trick is finding, especially in somebody who can't tell you what's going on is, okay, is this, their belly's a little upset or do they have appendicitis? Did they twist their ankle a little bit or do they have a broken bone? And part of what our guessing game in medicine is trying to figure out which one's which. So in treating pain, we have to think about, we have lots of different modalities. So, we Western medicine docs, and I'm guilty of this, I reach for medicines a lot. Like that's what I feel like I'm good at. That's what's kind of easy for me to give you. Of course, they all have potential side effects. They only work if you take them. I do use a lot of pain medicines of both what we would call the regular variety and the not so regular variety, which I'm going to get into. But a lot of times, and especially these days, in the what I hope is the later stages of the opioid epidemic, I hope we're coming a bit to the end of that. I don't know that we are. But particularly as people are really aware of the opioid epidemic, a lot of people are worried to use sort of strong pain medicines or any pain medicines in treating their pain, and for various reasons which I'll talk about. But I will also say that not treating pain has side effects. Number one, you have pain, and you have chronic pain, and maybe you're losing function in something that you didn't have to lose. You don't have to be losing function. So just because you have side effects, a worry about side effects can go both ways. Now, again, in Western medicine, we don't spend enough time thinking and talking about non-pharmacologic therapy, but a lot of this is really, really important. And a lot of times, patients have tried a lot of these things before they even get to see me. And, hopefully a lot of people have a physical therapist they work with, or go to yoga class, or do some other thing where they're working with somebody who can help them with stretching, who can, maybe somewhere in your life you've had somebody give you a brace, and you can use a brace or not use a brace. Working, if you do use a wheelchair or some other sort of sitting device, working with your vendor to make sure that this is the right fit for you and that you haven't outgrown it, and that the cushion hasn't broken down in some way. Getting adequate sleep is extraordinarily important for treating somebody's pain. When they did these, you're not allowed to do these kind of studies anymore, but like in the 60s, they would take college students, healthy college students, and say, I wonder what it'll be like if we keep them awake for like a week and don't let them sleep. And every time they fall asleep, we wake them back up. And, people volunteered for this and got paid for it. So number one, they get really quite irritable and quite psychiatrically difficult, but they all complained of pain. Keeping someone awake for a long time, pain is restorative. Sleep is restorative for pain. I'm going to make a few mistakes during the talk, just in case you haven't figured that out. Pain is restorative, and so getting on a good sleep schedule is really, really important. Of course, pain interferes with sleep, keeps you up. But, and so these things go with each other. Biofeedback, thinking about your body, and a lot of this is sort of the yoga way. Doing exercise, using a whirlpool, using heat, using ice. People ask me a lot, okay, I turned this ankle, I sprained this, or I pulled that. Should I use heat or ice? And I say, try them both, see what you like better. For a muscle strain, I tend to think heat is better. For a turned ankle or something, I tend to think ice is better. But some people have the opposite reaction, and I say, listen, try them both. Massage, if you can get it. If you have a good friend who can do it for you, or a partner. TENS unit, and this is one of those things you're looking at me and saying, what is TENS? And I'm blanking on what it stands for in the moment. I go through it in a minute. It's essentially an electrical current that can be used to help fool the body in terms of working with pain. Things like complementary and alternative medicine. I want to go into that a little bit. So what's complementary alternative medicine? It's all sort of in the eyes of the beholder or who you're talking to. And what I think of as complementary or alternative medicine is just what they call medicine in China in some ways, and vice versa. What we call medicine in our system of thinking in another country might be alternative or complementary to them. And then orthopedic interventions, which of course are very common in people who have arthrogryposis. And a lot of times you go into those things hoping that whatever this orthopedic procedure is will help both with function and with pain. All right, there are lots of types of pain. We talked about this a little bit. There's this somatic pain. Somatic means the body, and so that's what we think of as sort of your normal pain. Again, I hit my thumb with a hammer, all right? Visceral pain. Your organs can hurt. They don't hurt in exactly the same way that a regular somatic pain does. So like if, for instance, again, I hit my thumb with a hammer, my thumb hurts. If I hit my viscera, like my spleen, for instance, with a hammer, or if somebody pokes me in the spleen, it doesn't necessarily hurt right here. It hurts where the nerves that sort of cover the spleen go. And where do they go? Like for the spleen and under the diaphragm, they go up to your neck. Your diaphragm is controlled by nerves up here in your neck. And so I remember this as a young kid thinking like, wow, like I feel really like bloated and gassy. Why does my neck hurt? And honestly, I just had lunch and I'm feeling this a little bit right now. Like I'm feeling a little bit of pain in my belly, but I'm feeling it up here because this is where the nerves are referred to. And so, if you have kidney stones, you may have pain in your back where your kidneys are, or it may radiate to a different place, into the groin particularly, because that's where those nerves go. Neuropathic, the nerves are what's painful or uncomfortable. And so if you have, pressure on a nerve like in ulnar neuropathy or carpal tunnel syndrome, if you have pressure on the nerve like you have knelt for too long, there's a nerve that goes around your knee called the peroneal nerve. And so people often who do a lot of gardening will get this. They sort of sit in one position for a long time and put pressure on this nerve. They get pain in their foot. And then, of course, again, with abnormal body mechanics, you may be pressing on nerves in unique kinds of ways. And there's this other thing called nociplastic pain, which we don't understand real well. But it very clearly is a real, true, not made up, not in your head kind of pain, even though we do think it's in your head in the sense that your brain is what mediates and controls this. And so, I sort of hate that, again, one of the things I don't like about my community of Western medicine is we think that a lot of people with chronic pain are faking it or exaggerating it or trying to get something out of me for it, or, like this kind of thing. Everybody's nodding their head. Thank you. I'm sorry on behalf of the doctors of the world. But I will say part of the reason is we don't understand it. That's not the excuse I should be giving you. We should be working harder to understand it. But a lot of people have chronic pain. It's very difficult for you to describe sometimes. It's very difficult for us to sort of put it in a box and say, hey, this is what we should be doing about this kind of pain. But it very clearly is real. It very clearly affects function. It very clearly affects people's qualities of life. And we need to think about it in a different way. It, to some extent, depends what kind of doctor you see. And so if you go to a rheumatologist, say, I've got this chronic pain everywhere, and I'm having trouble sleeping, and everything just hurts, they may say, oh, you have fibromyalgia. Okay, well, what's that? Well, fibromyalgia is a particular way of defining a chronic pain like that. And if you end up with a gastroenterologist because your pain is primarily in your stomach, but they do all the testing and they can't find anything wrong with you, well, then they say you have irritable bowel syndrome. Okay? Now, that's a different kind of pain, sort of localized in the bowels. And again, there are other doctors that you'll see and they'll put a label on this kind of pain. But what I'm here to say is that probably most of that pain is related to how the brain works and how the brain copes with pain and how the pain copes with the brain. And it's a vicious sort of cycle. And the problem is our, quote, usual pain medicines, which we're about to go through, nonsteroidals, opioids, whatever it is, they don't work for that kind of pain. We can give them to you, but you'll get side effects from it and it won't really help your pain. So that's why we're not real good with this kind of pain. And of course, a person can have both, more than one kind of pain. All right, I talked about this a little bit, nociceptive, somatic pain. Again, you hit your thumb with a hammer, Homer stepped on a nail, went right through his foot. There's tissue injury. If we did an x-ray or something, we could see something is wrong here. Or you can even see, like, the nail is sticking out of you. Like, yes, clearly, you have this somatic, sharp, aching, stabbing, throbbing pain. a scrape, a sprain, a broken bone, getting a shot, something we did to you, getting your blood drawn. What do we do for that kind of pain? So this is, again, what we think of as the typical pain medicines. Acetaminophen or Tylenol, mainstay of treatments. If you haven't tried it in a while for pain, go back to it, give it a try. Use a good dose of it. It works for certain kinds of pain. Anti-inflammatories like non-steroidal medications like ibuprofen, naproxen, Celebrex, I can name like sort of any one of them. I'm not advertising one or another of them. But these are medicines that work on the inflammatory part of your pain. And then the big gun, steroids like prednisone, they work very well on the inflammatory part of your pain, but they have a lot of side effects. And then when we need to, we can use opioids, like you broke your leg. I'm sorry you broke your leg. That really sucks. You know, I think you could really use some morphine or oxycodone or something until your leg feels better. That doesn't mean we're going to use opioids forever, but you know, you very clearly have had a severe injury. You should have that kind of pain. We can use topical preparations like a lidocaine gel or a lidocaine patch. If you have a particular spot that hurts, I'll often say put some of this, the cream that I use the most is Voltaren cream or diclofenac. It's a non-steroidal cream. You can rub it. It's like taking ibuprofen, but rubbing it right on the part that hurts. If you have a joint that hurts, I bet a lot of you have joints that hurt, a doctor can inject steroids right into that joint and decrease the inflammation. You sort of can't do that forever. You can't do that, you know, every week or something like that, but sometimes you can get a good amount of time from that and go forward from there. Then there are other invasive modalities like radiofrequency ablation and stuff like that. Ice and heat, massage, guided imagery. All right, this is that visceral pain I was talking about, where your organs are the ones that are kind of hurting. And so when you think about a pain that radiates from one place to another, that means it's probably traveling along a nerve. And so if you've ever had gallbladder pain, which a lot of people have, yeah, it hurts up here where your gallbladder is in your right upper quadrant, but again, it can also radiate around to your back, it can radiate up to your neck. And so part of this is you tell the doctor, hey, not only does it hurt here, it also hurts around the back like this, and that'll help them figure out where we're looking at stuff. What do we do for visceral pain, like, say, kidney stones? Well, somatic stuff can help, non-steroidals, opioids, and so on. And if we know that what you have is a kidney stone, we can try to treat your kidney stone. And if we know that what you have is gastroesophageal reflux, we can try to treat that, or constipation. And then all of the non-pharmacologic things, like, for instance, with gallbladder, changing your diet can be really helpful for that. Neuropathic pain is when the pain sort of lives in your nerves. And, of course, we have nerves all throughout our body, and their job is to tell your, you know, they're sort of built, you know, sort of when we were sort of more simple animals, don't touch that, it's hot, don't touch that, it's sharp. But you know, sort of with our sort of advanced way, the nerves are now really telling us what's going on, and they can be giving us bad information. And that's the way I think about this sort of what neuropathy is that your nerves are giving you bad inflammation. I got a couple of spots in neuropathy, and they bother me. It's annoying. It's not that big a deal. I know that a lot of people have much worse neuropathy than I do, so I try not to complain about it. But what I mean to say is, we'll get this from time to time. You know, when you hit your funny bone and you get that tingling in your pinky finger and your ring finger, that's a neuropathy. You sort of jarred your ulnar nerve. But people tend to not describe nerve pain the same way they describe other pain. And so when I say, tell me about your pain, and you say, it's a numbness, it's tingling, it's pretty uncomfortable. Like, you wouldn't think numbness would be uncomfortable, but it is. I feel like I'm getting weak. I feel like I can't feel things the way that I like to feel them. I mean, it's sort of weird, and it can be really quite painful. It can be burning or an electric shock kind of thing, going from one spot to another. The nerves can be irritated by something or through chronic stimulation. And what we run into with this neuropathy kind of problem is that The more the nerve is sort of revved up to carry a pain signal, the more it's revved up to carry a pain signal. And it's not doing us any favors when it does that kind of thing. And we need to use neuropathic pain treatments to try to hit that. So the nonsteroidals are not great for this. Your opioids are not great for this. Our mainstays of this are things that work on nerve fibers, such as anti-seizure medicines or anticonvulsants, antidepressants, and we'll talk about a few of these, and then like local anesthetics like lidocaine and so on. Of the opioids, there is one, methadone, which has pretty good coverage of neuropathic pain medicine. So if you have really severe chronic pain and it's got a neuropathic component, methadone might be the treatment. And then there's this nociplastic pain, which I mentioned, which is the one we don't understand real well. How do we define it? Okay, so you got pain, but there's no clear evidence of actual or threatened tissue damage. It feels like your head is going to pop open. It feels like your belly's going to rupture. It feels like you are, your knee is going to fly apart, whatever it is. I can't see that on an x-ray, but I can believe you that it feels like that, okay? It lasts, it's a chronic thing, it's got to last more than 3 months. It can be tough to pinpoint where it is that it hurts. It kind of hurts over here. It kind of hurts down in this leg, but I couldn't tell you it's that spot and not that spot. And we get these symptoms of pain hypersensitivity, which is to say that, you know, your normal sort of toughness about pain is taken from you. And like a slight pain, stubbing your toe, feels like a catastrophe. And it is a catastrophe. That's the way it feels. I'm not trying to say it shouldn't feel that way to you. The reason it feels that way is that the nerves are all revved up, and a little brush on the foot or some other thing, or the sensation of a sock on your skin can really like drive you quite mad. What do we do for this? So somewhat the neuropathic treatments like the anticonvulsants and so on, we'll get back to that. Physical therapy is helpful. Cognitive behavioral therapy is helpful. And I suggest this to people, and sometimes they look at me and say, you think I'm crazy. You don't think I really have pain. And I very specifically tell them, no, I believe you have pain. But I don't have a medicine that will just make it go away. What we have to do is help you learn to cope with the amount of pain that you have. I can lessen the pain to some extent, but we need to work on your brain. We need to work on the way you cope with things. We need to work on the way that you approach the world in order to feel the pain, recognize the pain. Allow yourself to say, okay, I have pain. Maybe I'm not going to get to do everything I wanted to do today. But how do you put that in a box and then live your life? And that's what cognitive behavioral therapy is about. Exercise and sleep. Those are the treatments, okay? It's not as easy as taking a pill. There's a lot less side effects to exercise and sleep. And so I'll prescribe that any day of the week that I can. But of course, they're hard to do. You know, it's hard to get to exercise. Everybody's busy, and it hurts to exercise if you have pain. But, you know, we encourage people to push themselves somewhat. You know, you shouldn't, you know, it's not a no pain, no gain kind of thing. You've got to push yourself in sort of measured ways to do this, and try to sleep. Check on how I'm doing on time. Not very well. Some myths about pain. All right, I don't even know if these guys are still on the air. Okay. If we give strong pain meds now, then when we really need them, we won't work. Okay, I can't take morphine now, because when I need morphine later, I'm not going to be able to take it. So that's one of these myths. We can always increase the doses of things. There's no ceiling on those kinds of medicines. If you need more morphine, you can have more morphine. We just need to do that in a measured and rational way. And if we don't treat your pain now, it can make your pain down the road more difficult to treat because your nerves get used to transmitting these pain signals. I'm going to become addicted. I have a family member who was addicted. I personally have a family member who died of an opioid overdose. Most people do, right? Prince and Tom Petty, they started using opioids, at least the way the story goes, for chronic pain that they had. But not everybody who has chronic pain gets to be addicted. And so what is addiction? To define it, Addiction is when you use a substance or engage in behavior that's compulsive and continues despite harmful consequences. Like you'll sell your air conditioner to get more opioids. Shouldn't have to do that, okay? What addiction is a treatable disease, chronic medical disease, that's really complex. There are genetic parts of this. It has to do with the way the brain works, the environment, and your life experiences. And just because you need a higher dose of a pain medicine doesn't mean that you have addiction. What you might have is tolerance, which is to say, this amount of morphine that used to work for me doesn't work anymore. That's tolerance. That means you need more morphine. That's okay. The body gets tolerance. Have you gotten dependent on the medicine, which is to say that if you don't get it, you start having withdrawal symptoms, sweating, irritability, high heart rate, things like that. Those are signs of dependence, which anybody who takes pain medicine may get over time. It doesn't mean that you're an addict, and it doesn't mean you're a bad person. It means your body has gotten used to taking that medicine, and if we want to stop using that medicine, we got to wean you off of it. Maybe you're having more pain because whatever's causing the pain's getting worse. Maybe you're getting what we call hyperalgesia, which is the nerves working overtime and really getting us into trouble. And maybe what you have is pseudo-addiction, which is you're trying so hard, or the doctors are trying so hard not to give you pain medicine, that you're then like watching the clock. When can I have my next pill already? When can I have my next pill already? And what that is really is your pain is undertreated, and if we sort of gave you the appropriate amount of pain medicine, as long as the other modalities, we wouldn't have that. Treating pain inappropriately may lead to addiction, okay? There are risk factors, and you should know them. If addiction runs in your family, you're more likely to have an addiction problem. If you use things not in the way that the doctor prescribes them, more likely to have an addiction problem. If you don't use other modalities like exercise and therapy and sleep and something else, you're more likely to have an addiction problem. If you run out of your pain medicine and take somebody else's pain medicine, you're more likely to have an addiction problem. That's not what we would call a normal behavior. So it's been a really big problem with opioids, especially like here in Ohio, as everywhere else. 1999 when I graduated medical school, and so like this is my whole career in this graph. I prescribed a lot of opioids that I probably shouldn't have earlier in my career because I was not really understanding how to look at somebody for signs of addiction. I believed they had pain, so I gave them pretty strong pain medicines. But I wasn't really working with them around other modalities, and I wasn't really working with them around sort of facing up to and talking about their addiction. All right, can't give you morphine because that'll depress your breathing. Sometimes we hear that in the hospital. Well, if you have a lot of pain, you're going to keep breathing. That's sort of the message here in the slide. So when we talk about a collaborative pain plan, there's a lot of stuff to consider. The age of the person we're taking care of, what their pain is like, when do they have their pain, is it just in the morning, is it just at night, is it all day long, does it come in waves, is it only after they've done physical therapy? Like those are clues about how we should do that. And then what are the goals of the pain? Again, for a lot of people, getting to zero pain is not really an attainable goal. So what is it we're really trying to do with your pain? Get your pain to a level where you can go to school, you can go to work, you can drive your car, you can do whatever, that's up for you to decide to some extent as to what is that thing that we're trying to get to. And the activity level. So lots of things go into the pain assessment, and I think the slides are available, so if you miss a picture, don't worry about it. Can you take an oral medicine? I can't prescribe you a big pill if you don't know how to swallow a pill, so I have to use a liquid pain medicine or a pain patch or something like that. And there are all these things that need to go into it. So again, for acute pain, everybody's got acute pain, and everybody can take Motrin, or not everybody can take Motrin. Motrin, if you have kidney disease, don't take Motrin, please. But people can take the things that they can take. Talk to your doctor about it. Most people can take acetaminophen. lots of people can take. Non-steroidals. The thing to know about acetaminophen is that they hide it in a lot of over-the-counter medicines. Without meaning to, you can take a lot more acetaminophen than you mean to, and that can be bad for your liver. So just sort of be aware when you're taking combination products. The non-steroidals like ibuprofen, naproxen, diclofenac, celecoxib, some of these are not FDA approved in adults. That means 10 minutes left, right? Sorry, thank you. You weren't giving me a 10 for the talk. Just checking. Okay. Thank you. These can really upset your stomach. Okay, so often we tell you to take it with food. Sometimes you have bad stomach and you can't take these kinds of medicines. And if you have chronic kidney disease or you're older, your non-steroidals are more likely to sort of be bad for your kidneys, so you got to be careful with them. This is a list of not all the opioids we use, but some of them. And the reason they're on a table is because to some extent they're interchangeable. They have different side effect profiles a little bit. They work on the receptors a little bit different, but the dosing is different. And so, the sort of what this what we talk here about the dosing is a lot of things are sort of in morphine equivalents. And so 30 milligrams of oral morphine is about equal to 20 milligrams of oral oxycodone, is about equal to 10 milligrams of IV morphine, is about equal to I think it's more like a milligram of hydromorphone. So again, when we can rotate things around as we need to, and they're to some extent not exactly interchangeable, but can be interchanged. And so if you're getting sort of tolerant to one of these, we can try rotating to a different opioid. But opioids have a lot of side effects: nausea, sedation, itching, constipation. Some of these get better when you take them for a long time, and some of them don't. The constipation is something that if you get it, it's always going to be with you, and you're always going to need a bowel program. It's not the end of the world if you really need opioids for your pain, but we got to pay attention to that pain medicine. But there are these risks of dependence and tolerance and addiction and diversion also, and who's in and out of your house, and who's looking in your medicine cabinet, and what do you do if somebody, your daughter's friend comes over and you notice a bottle of oxycodone's missing, like what do you do with that? These things have value out there. We need to be aware of them. So in terms of chronic pain, a lot of what we use are what we call these adjuvant or extra treatments: anticonvulsants, antidepressants, local anesthetics, complementary and alternative medicine. Okay, Neurontin or gabapentin, this is one probably most people have heard of. This sort of got its start in life as a seizure medicine. It works in the nerves. It's not the greatest seizure medicine, but for many people it works very well for their pain. And it's sort of our first go-to for neuropathic pain. It reduces the release of neurotransmitters. It does have some side effects. It needs to be dose adjusted. It is FDA approved, get this, only for adults with shingles and children over 3 with epilepsy. Let me come back to the question in a second. And then it has a cousin called pregabalin, which sometimes we use. Same thing, officially indicated only for shingles and diabetic peripheral neuropathy, but we use it because we know it works for neuropathic pain. The tricyclic antidepressants is a class that includes something like amitriptyline, nortriptyline, and other things that rhyme with tryptophan. Help with pain, help with mood, help with sleep. The FDA approval is only for depression, and it does work for depression, but it's really helpful for sleep, and it's really helpful can be really helpful, again, for chronic pain. Has these side effects, somewhat more side effects than gabapentin does. There's another class of antidepressants called the serotonin norepinephrine reuptake inhibitors, of which Effexor is one of them. And this is something that I use in somebody where they're having a lot of trouble with their mood and anxiety and pain. It's really well tolerated, and I think it really works for some people for their pain. And then there's all these non-pharmacologic things: stretching, bracing, adequate seating. I think we talked about this already. Massage and so on. So about complementary and alternative medicines. so that there's this sort of term can. Complementary means you're using it in addition to what we would consider regular medicine. Alternative means you're using that instead of what we consider regular medicine. So I will say there's a growing body of evidence that a lot of this stuff really works and really can be helpful. I'll say for me, I am a fan of complementary medicine because I think the things that I do are helpful, but I think they can be really potentiated or improved by also doing yoga or acupuncture or Reiki or sort of one of these other things. A word about herbal medicines, just because they're natural doesn't mean they're safe. Lots of things we use in adult medicine or regular medicine, digitalis, that's natural, but it'll kill you, if you take it the wrong way. And I worry about when you get things sort of in a over-the-counter from the supermarket instead of from the pharmacy. Do you really know how much of whatever is in that pill? And do you really know that that pill is the same as the pill that you got last week? And there could be interactions there. Relaxation, super important. Easier said than done. Massage and aromatherapy. Aromatherapy is a real interesting thing because the nerves to your nose go right into your brain and right near the pain centers. And so there are certain odors that really bring aren't there certain odors that bring you joy? Certain odors that really bring you terror and things like that? That's because the brain and the nose talk together pretty well. TENS, transcutaneous electrical nerve stimulation. These electrodes, they may sting a teeny bit. They should not hurt a lot. Therapists can work with you, and they, to some extent, overwhelm the nerve into stopping its abnormal transmission. Energy therapies, acupuncture, Reiki, a lot of my patients really swear by some of these things. I was a skeptic about Reiki. I ran a little study of Reiki, and it certainly looked like it worked to me. Reiki is the energy approach. They don't even touch you, but they think about your energy is moving through your body. Okay, and so this is again one of these things that acupuncture sort of comes from China, and people have been doing this for a long time, and I don't know what's there. I don't know why it works, but I do believe there's something there. All right. So in summary, there are many reasons why a person, particularly a person with arthrogryposis, may have pain. There's many possible solutions. You really need to work with a doctor who you trust and trusts you, and a multimodal approach is best. Okay. So I think I probably got it right under the wire. I think there's probably a few minutes for questions, which I'm happy to take, and I'll hang around for a little bit afterwards, too. Thank you.